All right, guys, it's officially 12 noon. Welcome to episode 146 of the 988 Crisis Jam, where this week we'll be discussing building sustainable crisis systems. And of course, the one and only Paul Galdys will be joining us today as our featured presenter. So let's get started. And again, just to keep in mind that we do have a new registration system, but it is very easy, I promise you. If you or your colleagues would like to join, please make sure that you're sharing the registration link, that it is linked to their work or personal account, whatever account for Zoom that they will be using to join. It has to match one-on-one so we can get your registration approved and you can be here every week with us. And then, of course, you can find all of the recent Jam highlights, the various segments broken out. The website is talk.crisisnow.com. We will have the videos, recent videos, old videos, and of course, you can go to our YouTube channel to see these are some of the top 5 videos in terms of views on YouTube and in-person Zoom links. But whatever you want, top 5, top 10, whatever topic you want to see, we have it all archived, so please check it out. All right, and this jam over the course of 3+ almost 4 years, we've had over 400 unique speakers across 140 episodes. So there is a good chance that we have covered your topic. But if we haven't covered your topic that you're interested in from the angle that you're interested in, please let us know. We will get you on here as a subject matter expert to tell us about it, or make sure that we're just sharing it with other folks. So all the speakers listed there, and hopefully your name will be added soon. Just an update across the crisis news system. And as we offer every week, a recap here, what we see from the Los Angeles Times, offering 3,000 new mental health and substance use treatment beds, again, in an effort to end a lawsuit. We know lawsuits help spur action, unfortunately. We see here in this article from News Channel 5 Nashville that private psychiatric hospitals are often declining folks. Again, you know, it takes a lawsuit, it takes action, because there are policies, laws, and regulations in place to stop this from happening. And I actually want to bring in Dr. Brian Hepburn to tell us a little bit about what's occurring here.
So Laura, thank you. Excuse me. I just wanted to say a few words about EMTALA, the Emergency Medical Treatment and Labor Act, which means that individuals have to be stabilized before they're transferred. That's part of it, right? The other part of it is that receiving hospitals, if they have a bed, have to accept individuals. And this is whether they're acute general hospitals or private psychiatric hospitals. So when you see a situation like this, we should always think that there may be an EMTALA issue here. EMTALA issues rarely come up on the physical healthcare side because hospitals are very vigilant. Frequently, however, EMTALA is not very well monitored on the mental health side. And that's something we need to do a better job of. Otherwise, it appears that our system is broken when, as you said, Laura, the problem may not be that the system is broken. It just may be that rules are not being enforced. So thank you.
Yeah, well, thank you, Dr. Hepburn, for that. I also want to note, while we're talking about rules being enforced, there is a parity rule that is currently open for comment. And I know a lot of the mental health organizations like Mental Health America have easy ways for you to add your comment and whatever you may want to. So I'm sure someone from MHA is here, they could put a link there. But let's talk about SAMHSA, right? They've got some good things for you if you are interested in talking about 988. Everyone loves magnets and kind of little cards and stickers. You can get all of that for free, up to 326 items. So check out that link. Yeah. It is in the chat, so you can get those stickers and free items. You can also get a free t-shirt from the Crisis Jam. There are hats, short sleeve, long sleeves. You can pick any of your choice of colors, logos, sayings. But in order to get this for free, unlike SAMHSA, you have to participate in our hot seat. So or our over under. So make sure if you don't want to get in the hot seat, you can order these, but of course, free is always great. So let us know if you're interested in participating in the jam, and we'll make sure that you can have your choice: colors, logos, sayings, Spanish or English. I think I have a hat and a shirt. So I won't tell you how many times that correlates to me being in the hot seat and if I was successful, but you get it whether or not. So please let us know. Oh, thanks, Gail, for sharing. Gail wore her shirt, or Gail wore their shirt while teaching mental health first aid. Lots of compliments. It's a good conversation starter. And so I'm going to pause. We have a video here that I think will just help us with, again, some of that fun we've talked about at the beginning.
Business, numbers. Is this working? Business, numbers. Is this working?
So we're going to be doing hashtag math today. And that makes me a little nervous because I am not great at math, but I know for folks who are on social media, we've been seeing things about girl math and boy math and the Roman Empire. Well, we've got some crisis math for you. So we are going to start with our over-under, and our over-under guest today will be Dr. John Draper, who serves as the president of R&D at Behavioral Health Link. And so we're talking crisis math. Stick with me.
I'm trying to. Here we go.
3 core elements, right? So we got the number 3 core elements. According to SAMHSA, for serving people in crisis, the crisis contact center, the mobile crisis services, the stabilization services, at each level of the contact center or the crisis continuum, individuals will be served, and hopefully their crisis could be resolved or de-escalated, all the way up into that 3rd level, the crisis stabilization level. So John, you still with me?
I'm trying to be.
This is a lot of math.
Hey, I just got to preface this, y'all. I've had the distinct pleasure in the past of being a supervisor for Laura, and all she did was ask me questions I couldn't answer. So that's about to happen now.
Well, let's not stop. What a good thing we had going, right?
Let's do it, Laura. Come on now.
I believe in you. I know we had some things last week, but I believe in you this week.
Okay. All right.
If we follow the logic of the crisis care continuum, being able to resolve, de-escalate crisis at each step across the continuum, what is the percentage that individuals would need the more costly care that happens beyond the call hub, the mobile crisis service, or the crisis facility? So outside of the continuum, what is the percentage of individuals who need the higher level of care?
All right. So as I recall, it was 80% for the crisis line, 70% so of that remaining 20%, 70% of that could be resolved with mobile crisis. So whatever, I'm already getting lost, but of that, then that 30%, the crisis facilities, I think, could resolve 75%, something like that. So then that's a 25% of 30% of oh God. And then there's like then the wraparound services beyond that, I think, were 65%. So I don't really know I don't know how that adds up. I have to get my calculator, but gosh, I think
audience is believing in you, John. You've got Megan.
All right. So this is, basically that makes me really happy to say, like, my gosh, there's like so little that would be left for inpatient. But if we could get the wraparound services in there, which we desperately need as well, I would say 5%.
Got your official. All right.
Yeah.
Let's see. Folks believe in your reasoning, but the math, they're questioning the math, but they believe in your reasoning.
They should. It's the right thing. Question my math is yes or no, is absolutely, please question it.
So we did this before the crisis jam started. I got the correct answer, but I was like, my pathway there was wrong, but I got the right answer. So maybe I got half credit. Let's see, has everyone submitted their guess? And do we see, okay, here we go. Oh, John, this is close.
They don't know.
49%
There's not some
are
good
think
math
that
out
you're
there.
too low. 51 think that
Yeah.
that it's under. Let's see. The correct answer, again, this is based on research that came from Margie Balfour. Again, you were pretty close, spot on with the resolution numbers. But when we break this down even more, and again, this is math, so stick with me. We take a look at this from Margie, yeah, why am I talking about it? Margie,
Yeah,
are you here? This is like a 50-50 split. We need you to walk us through this.
No, I am here, but I've never calculated it that way. So, I think, so each of those are the community disposition rates for each service. But I didn't say someone starting at the crisis line, because like people can enter the crisis facilities other ways than via mobile. So technically, like to answer if you wanted to follow somebody from when they called the crisis line, then went to mobile, and then mobile people who then went to the crisis facility, like what percent are people who arrive by mobile discharge to the community? Like I could do that calculation, but I don't think I have, because that includes
So
people who
David did this for it.
Yeah, that like the 65% includes, and this was for all the crisis facilities in Southern Arizona, which there were a handful, so not just ours, but they can arrive via walk-in, ED transfer, and then mostly in police. So
so David calculated this, and if we don't believe him, we can
and it
just
is
blame him.
early to do math for those
It
of
is
us
hard, but
big time.
he mapped it out across, starting with someone who kind of started with the call center, any call center, about that's 80% resolved. So if we look at 25,000 calls a month, that's about 5,000 folks who would move on to a mobile crisis team. That would be resolved 70%. So 1.5 thousand folks who would be in a crisis stabilization center, and then 525 folks who would move on to a higher level of care. So that roughly translates, according to David's math, to 2% of individuals. So I use the 988 Lifeline. 98% of our calls and contacts are resolved without the need of police intervention or other higher level intervention. So that's how I got to 2%. It is incorrect.
That's a shortcut. That's a short, but it worked. It worked.
It worked. So John, we'll have to bring you back next week and we will attempt again.
No,
But thank
not
you
again.
for continuing our
Thank you.
tradition.
Appreciate it. See you
No
later. Liz.
problem.
Bye-bye.
See you, John. So I'm going to ask Bree to come on camera. Bree Maselli, and I apologize if I have butchered your last name. Bree comes to us from Maine Department of Health, and I'll let you introduce yourself.
Yeah, so I'm Bree Maselli. I'm the Mental Health Division Manager at Office of Behavioral Health at the State of Maine Department of Health and Human Services. So thanks for having me.
No problem. Thank you for being in the hot seat, Bree. And again, she will get her choice of t-shirt, hat, but we were talking about people who will move through the continuum. And as we go across the continuum, that cost of care gets higher. So if we look at the calculator.crisisnow.com, that calculator suggests if we fully implement those 3 core crisis services nationally, it would create a cost avoidance of unnecessary medical costs. So again, when we divert from relying on inpatient and hospital EDs, those costly care levels, based on that calculator suggestion, what would be the cost savings for the whole continuum, the whole healthcare system, if we fully implemented those 3 crisis legs. So you have a choice here, Bree, of A, B, C, or D.
Okay.
And you'll see here,
I get some assistance here, which I appreciate. Anyone's support in the poll.
there anyone you'd like to bring up to help talk you through it?
Well, let's see. I think I'm trying to think who I have in the room that I know that is always looking at this type of math and cost savings. And so let's see.
The audience is suggesting bringing back John Draper because his reasoning is strong. His math
I know,
is
I was
questionable.
Yeah, I was thinking his math. Yeah, let's bring John back.
All right, John, you're back.
God help you, Brianne. God
Hey,
help you.
you got right to that, percentage in a really great logical way.
Yes, I was still wrong though, don't you see?
I know, but I do like your logic behind it.
Oh yeah, yeah. I mean, I just I don't think I have any logic beyond this, except I know it's substantive savings. I mean, the
Yeah.
38.9 million is just way too little. I think 389 million is nothing compared to what I
Nope.
believe it
I agree.
actually is. So I'm thinking it's going to be C or D. So I'm going to lean towards C, and wish for D.
Yeah, I was thinking D was also wishful thinking. So
Let's
let's see I'm seeing a little poll screen here.
We've got 49% of the audience saying C, so they're
C.
agreeing with
Yeah.
your logic. Right, and C is 100 times, A, D representing 1,000 times. And based on that Crisis Now calculator, which is again available at calculator.crisisnow.com, the correct answer is actually D,
Wow.
38.9 billion. So the sky is the limit. We're getting what we're hoping for, but that is all based on a national, fully implemented crisis care continuum. So states, I know we can do it.
38.9 billion a year.
Think what we could do with that money.
Wow. Wow. I was definitely thinking that that would be ideal, but I didn't quite think we were there just yet. So
well, we could
great.
get there once it's fully implemented, and states are going to be the ones leading the way. And so I think we're going to roll into our featured presentation, which includes our math wizard. Oh, no, we're not. I'm sorry. Before we get there, last Thursday, there was a meeting of historic meeting of former and the current Surgeon Generals. This is where this quote comes from. We need leaders who care enough, leaders who know enough, leaders who will do enough, and who are persistent enough until the job is done. Great quote. And again, from my perspective, you don't have to be a Surgeon General to be a leader. All of you here today on the call are leaders in your respective communities and areas. And yes, and you guys do care. So a lot can get done so we can reach that $38.9 billion. So great job, Bree. Thank you for this quote. And now I'm going to turn it over to our math wizard, Paul. Paul?
Thank you, Laura. A pleasure to be here. I think Bree said something that's really, I didn't think we were there yet, and we're not there yet. But what I'd like to do is talk a little bit about the tools that can help you get there. We introduced the Crisis Resource Need Calculator earlier today, and I want to go through a little bit of what that looks like and what it can do for you. And the other thing I want to do is give some insight into how do we really get to sustainable crisis service systems. What that does mean is get reimbursement right, get regulations right, so we can even do those services. And the savings is only going to come if we're getting diversion from the justice system, from the emergency departments, and we're connecting people to really care that looks like care. And I think when I think of sustainable, I think of lessening our reliance on grant funding, lessen our reliance on state appropriations for funding to deliver services, and get this as part of mainstream healthcare, where we're getting paid as providers for the services we deliver in a way that covers the cost. And that sort of modeling is going to maximize your use of the federal match and Medicaid, and also set a standard for how we could pursue parity. So that's some of my thinking. And in the next slide, we kind of show this concept of, look, we don't just want to get people in need connected to some sort of resource, but we want them to get connected to care that looks like care. And so regulations allow you to do that in some places, and in other states, you're going to be challenged. And so we'll lean into that a bit, but these are images of 2 crisis receiving centers. They take everybody that shows up. They do so in an inviting place. It's a place where individuals want to get care. And again, we get better outcomes when we can create environments for individuals that really work for them, natural light and other things. And this is just a little bit of a reminder that SAMHSA did publish the National Guidelines for Behavioral Health Crisis Care in 2020. And this best practice toolkit leans into what we would call someone to talk to, someone to come to you, and a safe place for help. And in those 3 sort of resources or core, what I'd consider, we call them National Guidelines for Behavioral Health Crisis Care, but look, behavioral health crisis care is broader than this. We know there's residential, there's respite resources, and other things that are very important to a continuum of care. We're really talking about these emergency behavioral health crisis care services that are going to accept anyone in need immediately. The analogy we've used over and over again is 911, EMS, and emergency departments there for anyone with a physical health emergency. We're talking about 988, mobile crisis response in the community, and a crisis receiving center that says yes to anybody in need. And when you get into those, they do provide some language that I think is very helpful. And so today, what I'm going to do is focus a bit on those core elements, where we can get funding these systems, how we can maximize federal match to make this real in your state. We're going to encourage data-informed models. So again, the crisis resource need calculator will be a big part of that, but we also need to know what our limitations are around our workforce, what's actually available, and how can we pull this off. So things you need to know. When I worked for Arizona Medicaid, my boss, Tom Betlock, really strongly encouraged us all to read John C. Maxwell book, which is Good Leaders Ask Great Questions. Fantastic. And I think if you're trying to get to the answer of how can we advance sustainable crisis care in your state and your county, you want to ask these great questions. And one of the questions you want to ask is, what is our actual need for these services? Should be able to quantify it in some way. And I'll tell you, if you're just looking at, well, we can count people in the emergency department, that's not going to get you there, because not everyone goes to the emergency department. We could count everyone in our justice system that's really there with mental health and substance use challenges, because we know so many people land there. That's also not going to get you there, because so many people are going without care at all. You could start surveying your homeless populations, but we're going to give you a resource that I think will lean into answering the question of not only is what is the need for you community, but also what does it cost to start up those services, and what does it cost to sustain them by payer type. And then I also think the other question we should always ask is, well, how do we actually reimburse and regulate for these services? So if I think of facility-based crisis services as an example, you may have crisis stabilization units, you may have crisis residential, you may have crisis respite, you might have a crisis receiving center. And if they are all tied to the same code, then you can imagine how difficult it is to actually get reimbursement in the right place. And although negotiated rates can happen, when you become a crisis provider that says, I am going to say yes to anyone in need, we really want to publish rates that are going to get to what it costs for that service. Because when we start pushing on parity, and many of you are doing this really important work, parity is going to look at, all right, what's Medicaid paying? And if the published rate is a respite rate because you're using the same codes and you've negotiated a better rate behind the scenes for this crisis receiving center that has 24/7 medical staff, you can see it will fall short. And the only way you're going to cover that gap is through your state general funds, It's going to be through SAMHSA block grants when there are far better opportunities to do those sort of things. The other question that's in here is, what can we do for startup? And, you know, it could be that you have funding sitting in your general fund. I'll tell you, SAMHSA in fiscal year 21 pushed out what 1.2 billion in supplemental mental health block grant funds. And when I got an update this summer, I had learned thus far, I think less than 15% of that was actually accounted for or used. So therefore, there could be as much as 1.3 billion between the states and territories that could be used for advancing this sort of work, getting it started, and then creating reimbursement structures that allow it to sustain itself as a mainstream healthcare service. So here's the calculator. Now to get to it, it's pretty straightforward. Calculator.crisisnow.com is the website. McKinsey and Company did this fantastic job taking what was a spreadsheet, grabbing publicly accessible data, going through a bunch of claims and other resources, and created this online interactive version of the calculator. And you can see there's two buttons there where you could click View Calculator. So if you click the calculator in there, the next slide is going to get you to a state map, and it's actually going to dig in and show you what does it cost to deliver services for individuals with acute mental health and substance use challenges. And if I look to the right, those bar graphs, the dark green represents inpatient costs. The lighter green up at the top represents emergency departments. And if you don't have a crisis system, that's how you're addressing acute mental health and substance use challenges. We know the justice system would be a part of that too, but that's not factored in here. And then what you'll see on the bar to the right is if you had a comprehensive crisis system with mobile response, with short-term crisis beds, as well as a receiving center and the acute inpatient and emergency department, costs are driven down significantly. And as Bree said, wow, didn't realize we got there. We didn't get there, but it is possible. And it's actually pretty straightforward math because we know what each service costs. And we know the average lengths of stay from multiple states that do deliver these services. And you can see there's a pathway in which just a person would either go to the emergency department, we know the escalation rate to inpatient, or we have individuals that could go this crisis pathway. Margie Balfour outlined that for us a little bit earlier today, and it's actually far less costly. And so if we go to the next slide, you can see I highlighted Pennsylvania there. I can go in, and when I click in Pennsylvania, I get a county map. And that county map can do a number of things. I can look at the cost for services in that county. It will tell me how many mobile teams I would need, how much each of those cost. Or in this case, I can also look at density of mental health licensed professionals in those communities. So as we look at the next slide, what we did is we pulled down a population of over 12 million in that state. And what it shows us is when we maximize and we're finally a fully functioning crisis system, how many episodes of mobile crisis we would expect and how much it costs to the right for those services. And this is for all payers. So keep in mind, this service, this online version doesn't really distinguish the payer. It just says this would be the total cost of services. All of these are edible. When you get in there, you can have a fun time playing with what's our time duration to get to a location. What would it cost for these sort of things? How many teams do I need? Do vary based on things you can edit in the system. So if we go to the next one, you'll see where it all started though. And where it all started is on crisisnow.com in the tools section. It's a spreadsheet, and you can see you just click there to download. And on the next page, what will pop up is you're going to see a spreadsheet. I do come from Medicaid and it's math day, so we might as well do a little spreadsheet time. And in the spreadsheet, it's going to show in red here, if I don't have a crisis system on the left, I'm just doing inpatient work, I'm going to need over 4,000 inpatient acute beds to meet the needs of this community. Again, it's a community of over 9.2 million people in this projection. If, on the other hand, we create a crisis system, instead of 4,463 beds, you can see right beside it in red, I need 1,284. A dramatic drop in your demand on the workforce, as well as the resource and costs you need for a system. What you would need to pull that off are 377 short-term beds, 444 crisis receiving chairs that you see below. And then I believe the print's a little small for me, somewhere around 91 mobile response teams. The benefit to getting this online, this version is in the spreadsheet. You can go to page 2. And on page 2, it will actually go and show you the cost by payer. And if you are a state looking at this sort of thing, if I go right through the middle line, I can adjust my payer mix for who's receiving those services. But in the mobile crisis response line, you see it projects at the bottom of that second middle graph, $24.6 million is what mobile would cost me. Not quite true though, because if I come down and I'm a county, state, other payer, our contribution as a state is actually 13.8 million. And so that's still a costly service, but that for this population of over 9 million people is what we think it will cost for mobile response for 91 teams. And if you go up a little bit more, 2 spots up, 6 million of that is for commercial individuals. They're insured. And in fact, if you can pursue parity, instead of paying 13 million, you're paying 7 million statewide for this state to have mobile crisis service access. This does include the enhanced federal match that comes with meeting the regulations that exist from CMS, so that 85% federal match for Medicaid. We go to the next slide, please. Other things you need to know are regulations, and I know we're tight on time, so I'm just going to lean into this piece. You have to have regulations for this 23-hour crisis receiving center. I encourage some flexibility around sharing space. Can we have a stabilization unit with the receiving center? Because in rural communities, you're probably not going to have the workforce to staff both. It becomes very expensive. So if we have chairs for this under 24-hour, and anyone that's there more than 24 hours gets a bed, and we have staffing appropriate for that, I encourage having some flexibility there. Same with mobile teams. Mobile teams, according to CMS for this enhanced federal match, don't require that you send a clinician on every team. You could telehealth in your clinician while you've sent a 2-person team, which could be this peer workforce that you develop that really engages the person, gets them support in the community, pulls in the telehealth, and that clinician is actually serving maybe 3 or 4 mobile team responses. And if you look at workforce availability, this is the last piece of what I wanted to lean into for you. And in regulations, one last thing, you're going to need to use seclusion to say yes to everyone. You're going to have meds on board. If your state regulations don't allow you to do that, you're not going to be able to operate a receiving center. Now back to the calculator.crisisnow.com. There is a workforce piece in there, and this is really around licensed individuals. So the list I have on the right are all workforce members I'd be focusing on. But in fact, it's all licensed behavioral health professionals there. And so if you click into a county, and in this case, I did, and I went into Westmoreland County, what you learn through all of this is, look, there's one licensed clinician. This can be a psychiatrist, psychologist, nurse, licensed behavioral professional for every 340 members of the population in the United States. In Pennsylvania, it's 1 out of every 400. And in some communities, the more rural you get, the more challenging this becomes. But like in Westmoreland County, it's 1 for every 520. So to be successful in Westmoreland County, it means you're going to have to be creative. And in the next slide, we lean into this idea that when you have a clinician, you probably can't have one fully tied to a mobile team, but they could serve multiple mobile teams through telehealth. They could be living outside of that community, engaging supports for you through those sort of resources. And the other part is sometimes they may serve multiple roles. You could be the clinician on this crisis unit that also takes mobile calls. And I think creativity is going to matter. Developing your peer workforce matters a lot, but sustainability is possible. Your state budget can pull this off. And in fact, I think your costs will drop as you fully implement the system. And the last warning I'll give around this crisis resource need calculator is that you are going to experience from time to time people that will project and say, oh, we're going to have thousands and thousands of mobile responses in our first year. Our facilities are going to be full. It takes time to build up census to get that change in pattern. So it doesn't mean you're going to have it in year 1. So as you set rates, you want them to be sufficient to cover the need as it escalates over time. Thank you so much for allowing me to jump in there, Laura.
Thanks, Paul. It's really helpful to walk through the math, and I like the way that you can use the calculator on the website as is and just have those assumptions, or you could go to the spreadsheet and change some of those assumptions. So we have Paul's email in the chat if you want to reach out. And now I'm going to bring in for a roundtable review, high-level thoughts on the presentation, Jenna Menert Baker. And Jenna, I apologize if I did not get your last name correct. But please share with us your thoughts on the presentation.
Well, obviously, I think it's really important information in the sense that Paul was in Pennsylvania on September 14th to talk to the Commonwealth of Pennsylvania as we work to implement the SAMHSA roadmap. And absolutely, I mean, I think he is completely accurate. The challenge from a state perspective is workforce and accessibility. I mean, having the services accessible within a distance that people will utilize, especially the the emergency behavioral health crisis walk-in centers, rather than going to an ED or someone being taken to a jail, have to be close enough. But then, you know, the workforce challenges of having the appropriate staffing available, both at those crisis walk-in centers, so they are providing that medical function, and to do mobile crisis 24/7, 365, out in communities, at least a two people team, are really the significant challenges. I think people philosophically, theoretically, fundamentally believe in this transformation, but it definitely, staffing something with a firehouse model, both the funding and the people, and having those services accessible enough to step in as the counterparts for their physical health, you know, for taking people to the ED. Those are some really big challenges that obviously we're facing in the Commonwealth of Pennsylvania.
Thank you for sharing that, Jenna. Now let me bring in Charlotte Claiborne. Please, Charlotte, share with us your thoughts.
So listening to Paul's speech or presentation really just sounded like he was talking about our crisis center and the things that we went through here in East Baton Rouge Parish. One of the things that I wanted to stress was that the Bridge Center for Hope is the first and only crisis receiving center in the state of Louisiana. And with that comes challenges. And we did do quite a bit of the things that Paul discussed, but again, there were still obstacles that we had to face. So when I was listening to his presentation, it was literally everything that I had already wrote down. And what we did as a community is we did recognize our community needs. We did a lot of research several years prior to opening our center and tried to understand exactly what it was that our community needed, what would be best to help us and to help our residents to be able to provide the appropriate level of care for them. And what we were hoping to do when we did this research was it allowed us to calculate our potential cost to operate this facility. And then the next thing that we did, or in conjunction, is we engaged key stakeholders early and frequently. And I cannot stress that enough. And I'm glad that Paul had that in his presentation, because what we had to do, because we were the first and only crisis receiving center, Louisiana did not have a reimbursement rate for a crisis. So one of the things is we spoke to the State Department of Health. We talked to local and state elected officials, our managed care organizations, nonprofits, hospitals, and the licensing board were all examples of who we spoke to frequently. And we did this because we wanted to have them assist us in establishing our crisis services, and then hopefully avoid those future challenges. But we still end up having some. But to ensure proper reimbursement, I do advise, just reiterating what Paul says, that you need to make sure that everyone is on the same page for the type of services that your facility is intending to provide. And that is verify that the state licensing standards, the required staffing patterns, and the accreditation all align. Because what we found early on is that our pharmacy board licensing or licensing standards were different from our standards. So we had to recreate or kind of go back and figure it out and have it rewrote. What we was trying to do when we first established our crisis receiving center was a little bit different than what the state has. So we had to turn in information to have it rewritten to include the crisis chairs and things like that. And so I encourage everybody to just kind of make sure before you even go any further that everyone is on the same page, because the staffing pattern is really the key. Because if your accreditation requires a higher staffing pattern than what the licensing does or whatever, you're going to run into those roadblocks. And then last, one of the things that I wish we did, but we did not do, and that's in hindsight, is do a phased approach. When we opened, we just kind of opened everything. But in hindsight, we know that now, but I strongly recommend that everyone, if you're operating this and it's something new to the community, for you do a phased approach, because what that does is allows you to gauge the level of services you're providing, and then eventually you can progressively expand. And we know that most communities are creatures of habit, and so it takes time for everybody to embrace new innovative concepts such as the crisis centers. And the key among all of this is education and community involvement. So educate early and often so that everybody can learn, and then make sure you have frequent conversations before you engage in doing something different.
Thank you, Charlotte. Really great recommendations for folks who are looking to implement this in their community. And again, Jenna, your perspective from the state level, just so insightful. Again, want to thank Paul for walking us through that. And it sounds like, we really need to bring everyone to the table, not only licensed individuals, but expanding that workforce pool, making sure that all payers are there, private, public, otherwise. And so it's going to take all of us working together in order to realize that 38.9 billion cost savings. So very excited for this. And we're going to continue our crisis jam this week. And I'm going to pivot over to Dr. Richard McKeon from SAMHSA to give us a SAMHSA update.
Thank you. Thank you, Laura. Much appreciated. Well, first off, I'm very glad that I'm able to be here with you, because it means the federal government is indeed open. And will be, as you know, a continuing resolution did end up being passed for about 40 to 45 days. So we're okay until sometime in mid-November. So, so that got a lot of the news, obviously, along with other things. But the other thing that usually happens right at the end of a fiscal year is that it's a time when a lot of grants are awarded. So I just wanted to call people's attention to the fact that SAMHSA has now awarded its state 988 grants, its tribal 988 grants, our crisis center follow-up grants, and also from the suicide prevention branch, additional grants are there, including about 30 zero suicide grants that were awarded. Now, if any of you are going to be in Barcelona for the International Association for Suicide Research conference, I'd recommend that you stop into Brian Amadani from Henry Ford's presentation of very impressive new research data regarding the effectiveness of zero suicide. So any of you who are going to that meeting, I won't be there, but I was glad to be able to represent SAMHSA at the International Association for Suicide Prevention meeting in Piran, Slovenia, and was able to have numerous conversations with people involved in implementing national strategies for suicide prevention in different countries around the world. The components of the national strategies don't vary tremendously. They do have to be adapted to local conditions. But for example, a principle like reducing access to lethal means is vitally important, whether you're talking about pesticides in Asia or firearms in the United States, et cetera. So again, it was a very valuable meeting, and there's some very innovative work that has gone on in Ireland, Scotland, and Australia in suicide prevention. So I'd be happy to, and we had Australia on the crisis jam maybe 9 months ago, something like that. So at any rate, there's a lot that we can learn from other countries, but they are things that they can also learn from us. There was tremendous interest in 988. And you probably all know, and you don't, that Canada goes live with 988 in just about a month. So I will stop there and hand it back to you, Laura. Oh,
Thank
wait,
you,
I'm
Richard.
sorry. One more thing. Sorry,
Go ahead.
And we can move the slide as it was. No, yeah, I meant you didn't have to go back to the SAMHSA slide, but what I was just going to say is that in terms of the revision of the U.S. national strategy, it's now scheduled for a March 2024 release, and we have worked on the inclusion of a goal specific to crisis services as part of that national strategy, which will be the first time that that has ever happened. Okay, so now I'm really finished and giving it back to Laura.
Well, thank you. That's a very big update. So thank you for sharing, Richard, and glad that you were able to join us. So many great things coming out of SAMHSA. So looking forward to seeing that. You said March 2024. I'm going to bring in Megan Haupt from Nashville to give us an update on state crisis services.
Great. Thank you so much, Laura. What I really wanted to hone in on was the 988 video phone service. I really want to hone in on this because it is such a big deal. It's a huge deal for the deaf community. And the reason it's such a big deal, I know that 988 has several lines for special populations, but the deaf community is not just a special population that needs, a specific language. It's what happens when that language and those direct services are not provided in a direct way. So what used to happen was a deaf person would call a hearing 988 call center. The deaf person in crisis would be accessing a video phone that utilized an interpreter that wasn't trained in crisis. That interpreter would call the 988 call center. The person at the hearing 988 call center would only hear the voice of the interpreter. And that interpreter did not previously know the deaf person in crisis, and again, wasn't trained in crisis services. So the ability to convey the intensity or the accuracy of the crisis was very challenging. And so now what can happen, and this is so huge, is the deaf person can use their video phone to call another person who is ASL fluent at this 988 video phone service, have a direct connection. The ASL fluent trained crisis counselor can talk to that deaf person directly and see them. That is such a big deal to have accurate communication, to have a trained crisis counselor. It is phenomenal. And I also have known somebody, a colleague that ran a 988 call center and who had the experience of having somebody deaf call their call center, and the hearing crisis counselor felt like a complete failure when they couldn't respond appropriately to the person in crisis who was deaf. So everybody felt like they failed. So this is about success, great communication, and it's about crisis care that feels like care. So it's fantastic that not only is the person or the organization that is providing the 988 video phone service, they are deaf themselves, the executive director, and it is trusted by the deaf community, and it is led by deaf people. So this is really, really good. So I just wanted to put some emphasis in there, and thank you, everybody. Thanks, Laura.
Thank you, Megan. If I could just spend a minute on here, because we were so excited, Vibrant was so excited to launch video phone through 988, which of course is a partnership with SAMHSA. And this really came from a pilot that the Disaster Distress Helpline, which is another program that Vibrant works with SAMHSA on. And for years, the Disaster Distress Helpline had a TTY service that received no calls, no contacts, no TTYs. And that's because the community wasn't using it. And when video phone launched on DDH, we saw those contacts go up in the first 8 months of service. And it shows that, it wasn't that the community wasn't in crisis, it was just we weren't where they were. And that's the importance of this work. We have to meet communities where they are, what they want to use, and let them lead. So very excited to see this launch and looking forward to more specialized services launching for individuals.
Thank you, Laura. Right on.
Thank you, Megan. Yes, and I know Nashville has been a good partner in that. So let's keep that good vibe going. And I'm going to turn it over for our data corner. Matt Goldman, are you here? And would you like to introduce our speaker?
I am here, thank you, and very excited to introduce Kate LaForge, who is a doctoral student in sociology at University of California, San Francisco, and I have the great privilege of being on her dissertation committee and supporting her work. And she's doing some exciting research on crisis text and chat type platforms. And I wanted to highlight in Data Corner this episode just how much exciting work is happening in crisis services in general, including with lots of up and coming researchers like Kate. So Kate, happy to hand it over to you.
Great. Thank you so much for that kind introduction, Matt. Yeah, as Matt said, I am a medical sociology PhD student at the University of California, San Francisco. And I will drop in my slides I uploaded to Box in case you'd like to follow along. So I live in Portland, Oregon. I am a crisis text line volunteer. And today I'm here talking about my dissertation research. My research incorporates or exists right at the intersection of sociology and health services sociology, and that sociology provides a critical ethos for research and considers questions of history, power, and justice, and health services, which is obviously concerned with the day-to-day design, implementation, and improvement of interventions. For this particular study, which is called the Conduit Study, I'm exploring young adults' experiences with mental health services with a focus on crisis text services. The research is mixed methods. It includes a survey followed by text-based interviews. This was motivated by the rise in popularity and use of crisis text services, a lot through 988, and also what I see as knowledge gaps in our understanding about the user experiences of crisis text, what motivates people to use crisis text services, what stops them from using them, and how things like cost, privacy, and technology fit into use decisions. And very importantly, where young people see crisis text services fitting into their mental health care ecosystem. And so to get at that, I ask questions about enrollment in therapy. I ask questions about history with EMS and 911 and hospitalization. I'm currently collecting surveys through the end of October. So the data I'm presenting today is very preliminary. And then interviews will take place beginning in November. And I am surveying, since I'm an Oregon-based researcher and I live and work here for years, my study sample is restricted to young adults age 18 to 24 living in Oregon. Yeah, so next slide, please. Thank you. So today I'm presenting some very preliminary findings. And what I have here is 3 items from the survey. And in blue, and then in white, you have the most common response so far. So the first one of the questions I ask is, thinking back to the last time you texted or chatted a crisis line, what went into your decision to contact them? The most common answer so far is feeling like a burden on people in my life, and that was about 62% of participants have said that. The second question, since you've heard of crisis text or chat lines, but not used one, what stopped you? And this is a very small sample of people who've heard of them and not used them. But so far, 100% of those people actually said they didn't think it would help. And that was the reason why they didn't use one. And thirdly, I asked, what would stop you from calling 911 if you had suicidal thoughts? And the most common answer so far, which has surprised me, is fear that it would cost too much. And I highlight these 3 questions and most common responses so far because I think they highlight 3 different spheres of decision-making and situations. The first being very social, the second, a question of effectiveness of the service, and the third is a structural barrier to reaching out. Other questions include questions related to mental health provider, the importance of involvement in treatment decisions, how crisis text lines change suicidality and satisfaction with the conversation with the counselor. I'm very eager to complete data collection and report on these findings, which I'll be reporting out in probably 2025. These are findings from the survey. As I move into the interview portion, I'll be using grounded theory, which is a very emergent model. So that will be really fascinating because I'll really follow participants in those interviews. In those interviews, participants will be able to participate via text, phone, or Zoom. So I imagine a lot of those will actually happen via text. And those interviews will really be what we talk about will come from what I find in the survey. So anything that you're seeing here and more findings in the survey will then be used within the interviews. So I'm very eager to see what people have to say there. For future work, I'm really interested in a larger scale survey. As you can see, this is a fairly small sample size. I'm hoping to do larger scale work in the future and work with different populations, including older adults, rural populations, and others. I'm also very open to collaboration. And as I go into interviews, happy to hear from anyone on what they think I should be asking or talking to participants about. On the first slide, the QR code is a link to my website where you can find my contact information. Thank you so much. I'm happy to be here.
Thank you so much, Kate. Again, these slides will be available on our website, on the YouTube channel. So please, if you want to participate, please reach out to Kate. Very excited to see those survey results. So now we're going to move on to a crisis talk, and I'm going to invite Stephanie Hepburn to share with us a recent conversation and article from Dr. Erin Emery Tabucchio. I'm hoping I said that correctly. Stephanie, I'll turn it to you.
Thank you. Yeah, so she's the co-director at the Rush Center for Excellence in Aging, and I'm very glad that you're jumping on this segment with me, Laura, because I believe you recently heard her speak in a panel. But what stood out to me is how ageism results in all kinds of assumptions. And two that she highlighted is that they often result in a lack of treatment. So that might be not screening for depression, which is because of this assumption that as people age, they inherently are depressed, which is not true. Or not screening for drugs because an older person wouldn't do them. And so she gives some examples like that within the article in our interview. And she also shares that the number of geriatric specialists, which were already incredibly low, that number has decreased since 2012. And we talked about COVID, of course, right? Because older people were more vulnerable to the virus itself and continue to be. But they also are more apt to live alone. And so that's not just social distancing or physical distancing, that becomes isolation. So those are some of the things we talked about, but I'd like to direct readers to check out the article.
Yeah, I think that article is really great, Stephanie. And so I had heard her speak on a U.S. Senate Aging committee panel on older adults and mental health. And one of the recommendations that came out of that panel discussion from the good doctor was this notion that we really needed to encourage primary care physicians to be a one-stop shop, particularly for older adults, and ask those questions around substance use disorders and ask those questions around mental health. And again, without giving too much of your article, because we do want folks to read it, did you all how did that conversation, was that woven in? Was there discussion around older adults sort of being neglected as we talk about mental health and the lifespan? And there's a lot of focus on youth, but not as much on older adults.
And there's some commonality, now that you're saying that, what stands out to me, you're talking about primary care and that being a connection. We know that in mental health, behavioral health generally, we're dealing with workforce challenges. And it's interesting because when we're talking about youth, there have been innovations in order for primary care pediatricians to be that connection. And there are also hotlines that they can call and consultation lines that they can call to connect with a psychiatrist. So you're right, because there's certain things that they could do, whether it's renewing a prescription, for example, the person is stabilized and they just need the prescription. So I love what you're bringing up. We didn't talk about that, but it just makes me think, a service similar to that could be fantastic for older adults as well.
Yeah. Well, again, the doctor is presented on a prior crisis jam. There's the link. The Crisis Talk article is linked in the chat. Please read that. Coming up, We have a Crisis Jam showcase from Utah, which has really been the heart of the 988 discussion, giving birth to the idea of a 3-digit number. The Huntsman's Mental Health Institute will be on October 11th, discussing the great work that they are doing. So please be sure to join us every week. Next week, we will have Kevin Curtis on. It's going to be jam-packed, full of great information. And then we'll have our first Crisis Jam debate, October 18th, around AI. And is that the future of crisis care? So we have Dave Atkins taking the yes position, and we'll have Dr. John Draper back to take the no position. This is going to be incredible. So please join us next week and the weeks after that. So thank you all so much. Have a great rest of your day.